Today, let us discuss about platelet disorders. First, let us see about the platelet plug formation, that is primary hemostasis. First, injury to the endothelial cells leading to the expression of the collagen. VWF binds to exposed collagen. VWS is formed from Weber Pellide bodies of the endothelial cells and alpha granules of platelets. Next, platelets binds VWF via GP1B receptors at the site of injury. Platelets undergo conformational change. Platelets release ADP and calcium necessary for the coagulation cascade. Then ADP helps platelets adhere to the endothelium. Next, activation. ADP binding to P2Y12 receptors induces GP2B and 3A expression at platelet surface. Rapid irreversible platelet aggregation. Next, aggregation. Fibrinogen binds GP2B and 3A receptors and links platelets. This results in temporary plug formation. This stops bleeding. Unstable ones, early dislodges. Next step is coagulation cascade. Coagulation cascade is also known as secondary hemostasis. Here, first is injury, second is exposure, third is adhesion, 4A is activation, and then 4B is aggregation. See here, for the formation of the platelet plug, this is also known as primary hemostasis, injury to the endothelial cells leading to exposure of collagen, and then which leads to VWF binding to the collagen. Platelets bind to VWF via GP1B receptors. Platelet releases ADP. ADP binding to P2Y12 receptor induces GP2B and 3A expression. Then fibrinogen binds GP2B3A receptors and link platelets. This stops bleeding. Next continues with coagulation cascade, which is also known as secondary hemostasis. Now, let us see the platelet disorders. All platelet disorders have increased bleeding time, mucus bleeding, and microhemorrhages like petechiae and epistaxis. Platelet count is usually low but may be normal in qualitative disorders. Now let us see Bernard-Soulier syndrome. Here the platelet count is normal or decreased. Here it is a qualitative defect. Increase in the bleeding time. Autosomal recessive, defect in adhesion, decreased GP1B. Decreased platelets to VWF adhesion. Abnormal ristocetin test and big platelets are seen. Here you remember B Bernard and B big platelets, and bleeding time increased B and here decreased GP1B. Here also remember 1B. Next, Glanzmann thrombasthenia. Normal platelet count, increased bleeding time, autosomal recessive, defect in aggregation, decreased GP2B3A. Blood smear shows no platelet clumping. Immune thrombocytopenia. Here we see decreased platelet count, increased bleeding time, destruction of platelets in spleen, increased megakaryocytes on bone marrow biopsy, and decreased platelet. Next, uremic platelet dysfunction. Normal platelet count, increased bleeding time. In patients with uremic failure, uremic toxins accumulate and interfere with platelet adhesion. Next, thrombotic microangiopathies. These disorders overlap significantly in symptomatology, may resemble DIC, but do not exhibit lab findings of consumptive coagulopathy. Thrombotic thrombocytopenic purpura, typically seen in females, inhibition or deficiency of ADAM TS13 causing decreased degradation of VWF multimers, which leads to increased platelet adhesion and aggregation. Triad of thrombocytopenia, microangiopathic hemolytic anemia, acute kidney injury. Along with this, fever, neurological symptoms are also seen. Lab findings are normal PT and APTT, which helps to distinguish thrombotic thrombocytopenic purpura and hemolytic uremic syndrome from DIC. Treatment: plasma exchange, glucocorticoids, and rituximab. Hemolytic uremic syndrome, typically seen in children, predominantly caused by sugar toxin producing E. coli infection, which causes profound endothelial dysfunction. Triad of thrombocytopenia, microangiopathic hemolytic anemia, acute kidney injury. Here, along with this presents with bloody diarrhea, whereas in TTP, it has fever and neurological symptoms. Next, von Willebrand disease, increased bleeding time and normal or increased PTT. Defect in platelet adhesion, intrinsic coagulation pathway defect causing increased PTT. Most are autosomal dominant. VWF carries or protects factor 8, leading to intrinsic coagulation pathway defect. Ristocetin test normalize after adding serum. Treatment is desmopressin, which releases VWF stored in endothelium. Thank you. If you like this video, please do watch, like, share, and subscribe.